ये बैकग्राउंड धुंधला नजर आ रहा है तो उसको थोड़ा
Assalamu alaikum. Uzair, can you hear me?
Yes, ma'am, I can hear you.
Assalamu alaikum. My name is Kiran Amir and I'm Director of Operations at Barsa Eco Pakistan Super Hub. I would like to welcome you all to the virtual workshop on diabetes distress screening in collaboration with Ferocins Laboratories Limited. Before I hand over to the moderator of today's workshop, we have to go through some standard announcements. We are part of a global movement called Project ECHO, based in USA, with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for questions or use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel. Link will be shared by Uzair in chat box. For the convenience of folks, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. I will now hand over to Dr. Usman Musharraf, Consultant Endocrinologist, Allied Hospital, Faistabad. Basically, I will hand over to the Ferocins team now. Thank you. Ferocins team.
अच्छे अच्छे आते हैं। ये तो बहुत ही हल्का है
सर ये सैमसंग की है।
हाँ
सैमसंग की ओरिजिनल
नहीं आवाज अभी तो आवाज नहीं आ रही है। देखें आवाज नहीं आ रही है।
So we are waiting for Ferocins team to take charge. We are still waiting for Ferozan's teams to take charge.
Yes, Assalamu alaikum to all. Miss Natalia, you can start meeting right now.
Assalamu alaikum everyone. We are just waiting for Dr. Smart, who is our moderator. So he'll be joining just in a few seconds.
Assalamu alaikum. Assalamu alaikum, Miss Natalia.
Yes,
How are you?
I'm fine, alhamdulillah. How are you? Okay, over to you. Thank you.
Assalamu alaikum, Miss Natalia. Can you please start? Bismillahirrahmanirrahim. Can you hear me?
Yes, Dr.
Can you hear me?
Rahman. Yes, Dr. Rahman.
Okay, Bismillahirrahmanirrahim. First of all, a brief introduction of mine. I am Dr. Usman Musharraf, and I am currently working as consultant diabetologist and endocrinologist at Allied Hospital, Faisalabad. First of all, I am thankful to Ferozan Pharma for arranging this wonderful session on evaluation, on screening and management of diabetes distress. According to different studies, more than 50 studies across the world, we see the prevalence of diabetes distress is around 20 to 25%, both. So management is distress is a big thing that we are going to discuss today. A person with diabetes spends 168 hours per week or 720 hours per month managing their diabetes. So this session will be chaired by Professor Dr. Javed Akram, a big name in field of medicine in Pakistan. He is president of internal medicine. We're having two speakers. Our first speaker is Dr. Muhammad Tahir Khalile. Dr. Muhammad Tahir Khalile, he is consultant clinical psychologist, and he is an executive member of Pakistan Psychological Association, Islamabad. Our second speaker is Dr. Muhammad Imtiaz Hassan. Dr. Imtiaz Hassan is Director, Diabetes Institute of Pakistan, Lahore. We are having two panelists. Our first panelist is Professor Dr. Zaman Sheikh. Professor Dr. Zaman Sheikh is big name in field of endocrinology in Pakistan. He is probably the pioneer of endocrinology in Pakistan, and he is a legend endocrinologist. He is consultant physician and endocrinologist and director Sir Syed Institute of Cardiology and Endocrinology, Karachi. Our second panelist is Dr. Usama Ishtiaq. Dr. Usama Ishtiaq is consultant endocrinologist and diabetologist at Shifa International Hospital, Islamabad. So first of all, I will start our talk with, we will start our talk from our first speaker, Dr. Muhammad Tahir Khalile. I will request Dr. Muhammad Tahir Khalile to please start on his first talk on diabetes distress, his evaluation and management of diabetes distress. Over to you, Dr. Tahir.
Bismillah ar-Rahman ar-Rahim. First of all, I am thankful to the Firozan and the organizer for organizing such a wonderful event and very informative, and I hope it will be very useful. I'm thankful that Dr. Javed Akram, who was here, Vice Chancellor once a time, and now he is in Lahore and he is chairing this session. Currently, I'm also working as Dean Faculty of Social Sciences, Shifa Tamir Millat University, Islamabad. Just to add to my introduction, now I'm trying to get my PowerPoint presentation, and then we will go on. Okay. Can you see the presentation on your screen?
Yes, please.
Okay. Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. I'm glad that I'm with a galaxy of experts on this subjects. They are very well-known physician and diabetologists and endocrinologists, and they are deeply and profoundly understand this problem in the context of medical knowledge, or as well as the educational aspects of this disease. Being a clinical psychologist, my focus will be on the distress and diabetic distress, which is more common and prevailing in this population, and which sometimes a cause of diabetes from the literature we can see, or sometimes exacerbate the diabetes, and the person who is suffering from diabetes, he become depressed or develops some psychological problem, or he develops some burnout because of the failure to manage diabetes properly. In the today's talk, our main objective will be to understand the prevalence and health effects of particularly behavioral related health problems, because diabetes is a medical problem, but there are certain behavioral problems which are related to this disease. That is the unhealthy lifestyle behavior. Sometimes the person become rigid, he become not flexible, he is not complying to the instruction of the physician. It won't be intentionally, but probably due to some psychological reasons. And there are also some common psychological disorders. For instance, you are all very well-known physicians. You have noticed, for instance, like depression is very common, anxiety is very common, and stress is all the time there. And also there are certain behavioral disorders which could be addressed at the primary care level. But sometimes, unfortunately, majority of the primary care level physician, whether they don't have a time or to spend with the client, that they can resolve certain issues immediately, and they won't get chronic. Depression, anxiety is very common in diabetes. And another aspect I think you have noticed in your practice, that is the uncontrolled anger. That is also prevailing in this population. The distress, diabetes distress is very common, and the person who is living with the diabetes, he has this problem how to manage the diabetes, self-management, relentless, because there are daily activities, many instruction is coming, and when there is no manageable diabetic level, then the person gets frustrated, and that frustration leads sometimes to aggression, or sometimes when he has some introverted personality, then he internalized those things, and then he developed symptoms of depression. Anxiety is more common in this population. They have a problem with the management of the insulin, how to manage the insulin, particularly in case of type 2 diabetes. And when there is a raise in the HbA1c, then there is this also increase the anxiety level and even the stress level, which become the diabetic distress. It is sometimes taken mistakenly, and sometimes we mix with the depression, but sometimes there would be comorbid symptoms of depression because of the distress or the stress. And there are certain scales through which we can identify, or we can assess, or we can measure the level of stress or the symptoms of depression or the symptom of anxiety. There is one paper was given to me by the Ferozan, which I also utilize in this making this PowerPoint, but some I add my own instrument which we can use instantly, how we can detect the level of distress or depression or anxiety among our patients. For instance, like they have this problem area in diabetes, but there is a scale which is called DAS, a depression, anxiety, stress scale. It's available in Urdu, very easy to administer, and even anyone can administer this test, and then they can assess the level of stress, depression, anxiety, and these symptoms are very common in this population. The role of primary care is very important, because if they could provide some behavioral assistance to manage their lifestyle or to develop their self-management skill, then I think the role of the primary care physicians are very important, because that is the first step when the client confront or the client consult that individual for their diabetic problem, and later on they go to the specialist. But anyhow, it depends upon, sometimes the people directly go to the specialist. There is no certain referral pathway which could be followed, and that could be very useful, because at the primary level you can resolve certain unhealthy lifestyle behavior initially, and even you can advise the client regarding the diabetes, or if he or she is in the stage of impaired diabetes, or in the initial stage. But later on that could become a chronic. But I think this area is very important, and the Association of Endocrinologists or Diabetologists, I think, needs to address this issue at the primary care level, and they could arrange certain intensive courses for those who are working at the primary care. For instance, like we have basic health unit, rural health center, Tahsil headquarters. These are the places where the client first go and they consult the doctor for their problem. Then I think and I hope that they will organize certain intensive courses initially based on the educational grounded in the educational theory, or in the educational context, that they can educate initially the client to how to manage their lifestyle, and how to manage if they have the possibility of diabetes. Because in certain cases, they also develop some mental health issues, for instance, like depression, anxiety, and some people use substance. Probably in our culture, church are and hash are more prevalent. The other drugs are also the possibility, alcohol, also the people are taking. Then I think, and some psychosocial stressor, then that could be, at that time, that could be screened out and would be referred to a certain specialized center to treat them properly. I won't go on the prevalence of diabetes disease, because you are all very expert, and you are experts in this field, and you are working for many years, and working with the diabetic patient, and a physician in general. In my, because I work nationally and internationally, 12 years I worked in the mental health care system in Republic of Ireland. And I noticed that physicians are also very good counselor. They actually counsel their client as well. It's not just they are prescribing the medicine, or they are just relying on the prescriptive practice, but they also counsel their clients. They are very good counselor. But there is a need that how we can emphasize on the mental health issues, for instance, like diabetic distress, or the as a consequence of diabetic distress, the mental health problem arises, for instance, like depression, anxiety, and other mental health issues, how that could be addressed. There are certain social impact of the diabetic distress. For instance, like stigma, social stigma is also attached. Usually in our country, when someone has, like you have heard this because you are a physician, you came across with many patients, then they say sugar, suffering from sugar. And when they say sugar, then they think that this person is gone. And there is a social stigma attached, and sometimes that make the person disappointed when there is no management, there is no control, and on the top of that, when they have some financial problem, they cannot afford the treatment costs, then they increase this diabetic distress, and consequently it increases the level of sugar, and this is vice versa, make a vicious cycle. If the sugar increase, then the diabetic distress increase, and if the diabetic distress distress increase, then the sugar level increases. And these are all the psychosocial stressor, stigma, discrimination, and financial implication, all are related, and they are contributing in the exacerbation of diabetes, and sometimes that become hard to manage it, and that become unmanageable. There are certain signs you would have noticed in your practice because you are working and you are seeing daily patients, many patients. Irritability is very one of the known symptom. They can't sit on one place. They will feel irritable. Hello? Yeah. They feel irritable, and sometimes they have very short temper or easily flare up. Feeling of anxiety, panic, these are also available, and sometimes they have some feelings that this is very important, that they predict the worst. Most of the time that they will think that some worst thing will happen. And there is another aspect which we call optimism biasness. Sometimes they become biased and they think that the other people will get the problem serious or worse, and they will not get. Feeling worried about health, this is very common, and lower self-esteem when there is no improvement in their, and when they have depression, and depression has a direct link with this low self-esteem. Usually when they forget important things, this also increase their stress level. And when there is no management, like they can't use the diary or some other external aids to improve their working memory, and then they become indecisive. They are making mistakes in C1, even sometimes they are making blunders, they forget their PIN codes or other things, and that increase the level of distress. Sometimes they have concentration difficulty to concentrate, even they are watching television and they are not around and they cannot concentrate. They are reading the newspaper, very simple thing, and then they can't concentrate. And sometimes they procrastinate their activities. They will say, I will do later, I will do tomorrow, I will do an hour later. And upon procrastination, they procrastinate, and they become rigid, sometimes inflexible, and sometimes they have anger issues, and that create a problem in the family, and they can't interact. I think there is some problem in the system. Anyhow, I will keep on. Sometimes they develop sleep problem, and then they need tranquilizer for that or sleeping tablets. And they have also aches and pains, tension, and other disrupted sleep patterns. And this also increase the level of this distress, and this could be linked to the signs of distress as well. Appetite for food increase, sometimes decrease, and they have sexual problem also, which you have noticed in your practice. Depression is very common, and I think it's essential to deal at the primary care health level and to scrutinize there or to screen out there, and even there are certain time limited psychotherapies, but even the physician can consult the client, or some health psychologists, if they are available, they can provide counseling, or clinical psychologists provide in case of severe mental health problem, then they can provide talk therapy or psychotherapy. For depression, you can use, even as a physician, you can use these tests are available in Urdu. That is Beck Depression Inventory, Beck Anxiety Inventory, 90 symptom checklist. This measure many disorder like other OCD and psychosis and other personality issue. And DAS, which I mentioned, depression, anxiety, and stress scale. This is available, and objectively you can assess the individual who is suffering from diabetes to look at the level of stress, and also as a consequence of diabetic distress who has developed certain symptoms of depression, anxiety, and other mental health issues. Or you can do as usually the doctor asks the symptoms, and you can through the symptoms you can diagnose. There are also certain potential biological causes: thyroid disorder, nutritional deficit, neurological damage, substance abuse. These are also potential biological causes. Suicide ideation, sometimes it's very common when depression is very high, then the person who is suffering from diabetes, then he develop or he has suicidal ideation. And when there is impulsive personality traits are existing, then sometimes that person attempts suicide or commits suicide. Uh, Also, they have a problem to keep adherence with the medication, particularly the antidepressant. If they have, then this is also a problem which usually they are not in compliance to the medical or the advice of the doctor. You can identify certain solution at the primary level, solution focus, if there is some genuine problem. For instance, he forgets the important things, then you can advise the external aid, for instance, diary, or sometimes nowadays the Androids, they have different system. They can remember the important things. Sometimes they have difficulty to make decision, then you can also talk to them how they can make decision, and they should avoid certain important decision during the stress or during when there is a high depression or anxiety. Also, you can motivate them, and there should be locally, there are plenty of psychotherapy like cognitive behavior therapy or other therapies are available. But as I said, I work abroad and I work here. I think sometimes we have educational problem, or sometimes we borrow that techniques from abroad, then it won't work. But we have to indigenize our own counseling techniques and our own counseling paradigm to work with the clients, and that will be very helpful, and the client can get benefits from that. Certain behavioral activities which are important for the to work with those who are suffering from depression. Like suppose you can give some home assignment, like you can ask the client to go for exercise or some other recreational activities that he can enjoy his life, and that can improve the quality of life. In depression, there are certain problem solving techniques, for instance, like help the patient identify and define the problem. Sometimes they are not sure that is it a problem or this is just a vague statement he will give. Then you need to have talk to the client to do a brainstorming, to have different options of alternatives of their problem, and then you can choose the best one, and you can advise the client to choose the best one which is helpful for him and which can resolve his current issues. Also, you can arrange some follow-up sessions, and you can refer him to some specialized services, or you can do another 2 or 3 visits at the primary care level. But diabetes burnout is a very important issue that is usually sometime when there is a problem and the person in question cannot manage his diabetic level or sugar level, then he developed this burnout symptoms, signs, and sometimes he disengagement from self-care. He won't take interest to manage himself, and sometimes he is skipping insulin doses or tablets, and even he or she is not ready to monitor his blood level. This unhealthy or uncontrolled eating habits, risk-taking behavior, non-attendance at clinic consultations, these are the symptoms or signs of burnout, because they are disappointed, because they cannot control their sugar level, and then there is no proper counseling to counsel them how they can adopt certain measure that they can improve the level of their sugar. Through this, this is the chart which I borrowed from the paper have given to me by the Ferozan, and this is a very comprehensive chart. Initially, be aware that the people with diabetes may experience diabetes distress. At least, I think we need to keep in mind that those who are suffering from diabetes, they would have diabetes distress, and ask the diabetes districts about the diabetes distress, and then assess for diabetes distress using a validated questionnaire, which I mentioned, the DAS, or they have mentioned in their paper as well. But DAS is, we have translated that in Urdu, and also determine the psychometric properties of the scale. Then you can easily administer the scale, and then advise, any advice if you do, and assign some tasks or assign to some another health professional, and then assess him or her if there is any homework or assignment, then they can do that and arrange the follow-up sessions. These are the paper which they have provided to me. They have these emotional health guides for professionals. If anyone want, they can read. This is the communication and engagement, facing life with diabetes and fear of hypoglycemia, and psychological barriers to insulin use, depression, anxiety disorder, and diabetes distress. You can read in detail in this chapter, which is available, and Ferozan can provide to you that chapter. Now I have this putting priorities into practice, and there are 7 steps which I would recommend, and I would discuss with you that how we can reduce our stress. First of all, to minimize the stress level, then we need to reduce the outside load. For instance, like if you have extra load you have put on yourself regarding your work or regarding some other activities, then you need to reduce that one, and you can make your life comfortable. And when you make your life comfortable, then that can reduce the stress level, and ultimately that can reduce the diabetes distress. Another one is reduce the inside load. Like for instance, if you have some internal issues like internal negative thinking, or you have some problem internally, like suppose you have some you take the things, you take small things as big things, and you become easily distressed, then you have also to work on it and how you can make yourself comfortable and relaxed. Diet and exercise, that you know very well, you are all endocrinologists and diabetologists. Diet is very important, and usually this is a very big challenge with the working with these clients. They are not following, not complying to the diet regime, and they use their own wishful, or they use their own the way they like or the way they dislike. And also exercise is very important. There is a very famous Chinese saying that if you can't make a time for an exercise, then you have to make for an illness. Then exercise, and even if there is no such exercise, rigorous exercise, then they can go for a walk, which is very helpful. Through the walk, when they go for a walk, particularly with the family, then they can reduce their stress level and ultimately can manage their diabetic level also. There are 3 R's very important. The first one is rest, the second recreation, and the third one is relationship. The 3 R's are very important. Diabetic patient needs to have a proper rest, a proper time to give to himself or herself, and recreation also important. Recreation doesn't mean that if someone can't afford and they can go for certain activities or sports, but even they can go for a walk, they can chat with friends, they can phone with relatives, or they can have some walk to in the park or in another place which is available. Relationship, good relationship is very important. Social support is very important. When good relationship and social support are available, then the person who is suffering from diabetes, that can reduce the level of stress and ultimately will manage his diabetes. Keep in touch with friends and relatives. Sometimes we become isolated and we don't keep in touch with the friends. If they are far away, at least we can keep in touch with WhatsApp or with on the phone, and we need to have this connection, this social connection. Help others when they are in distress. This is very important thing. When you are going some charity work, when you are helping other people, then this can reduce your stress level, and this can also increase your well-being, and then ultimately this will manage the diabetic level. Charity for welfare and well-being, this is very important, and that is very good for the health. Thank you very much. These were few points which I mentioned, and if there is any question or anything, you can ask. And but this is the area which needs focus of attention, particularly at the primary care level, that if you could link the diabetes distress, because this exacerbate the diabetes, or it could be the cause of diabetes. Thank you very much.
Thank you, Dr. Tahir, for such a comprehensive talk. Now I will request every participant to provide us session feedback in order to claim CME. The participants submitting feedback within 12 hours would only be eligible for CME. You can see the link for feedback in your chat box. So for our second talk, I will request our second speaker, Dr. Muhammad Imtiaz Hassan, to please start his talk on screening of diabetes distress. Over to you, Dr. Imtiaz.
Thank you, Usman. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Sadaqallahu al-azim. Thank you, Dr. Tahir, for
Dr. Imtiaz, your voice is not clear.
My voice, is it okay now?
A bit improved, but still we have difficulty.
Can you hear me now?
Yes.
Yes, sir. Now,
so thank you very much, Dr. Tahir, for giving an excellent presentation, and you have given, you have made my task very easy. My topic of discussion is this. Basically, I will discuss, which you have just mentioned, the diabetic distress scale we are going to discuss. But before that, there are certain points that they need, because at times what we see in our clinical practice, that once a person is diagnosed in our clinical practice that he's a he has become diagnosed, he has diagnosed as a diabetic, so it's really like a bombshell which is exploded on his head, obviously, and it's a really shock and jerk for the family.
Sir, sorry for interrupting you, but the screen sharing has been stopped by Frozen. Can you please share the screen?
Yes, I think that Natalia can share.
Yes, I am sharing, sir.
Please.
Yes, sir.
okay.
So next, please. But because as we know that the American Diabetic Association recommends that providers screen patient with diabetes for depression and diabetes distress during their initial visit and periodically thereafter. I'm very glad that this was the least discussed topic in our scenario, because we people in our clinic, we do realize that this patient is suffering from distress, but we are not able to judge the patient or diagnose the patient correctly. And there is a very fine line between the depression and the diabetes distress that we cannot mark that line. So at times the most common problem for the physician who are working in a diabetic clinic is the time constraint, because the load of the patient, the burden of the patient is such that definitely you don't find enough time to screen all these patients for diabetes distress. But I think what we have done in our clinic and in our setting, that we have taken the help of the psychologist, and and we have trained in the field of diabetes a little bit, so just gave them some basic knowledge of the diabetes, and they are helping us in this regard. So we are referring to these cases, what we feel that this patient is having the problem of diabetes distress. So obviously, so the outcome is quite tremendous. So but as far as what is the frequency of this diabetes distress, it's quite common. That because as Dr. Tahir has just mentioned, 1 in the 4 people in the type 1 diabetes, because type 1 is more demanding type of diabetes, so the level of diabetes distress is very common. But in as far as the type 2, which is a very common disease entity, and 1 in 5 people, they have the type diabetes distress. So the first thing which we come across, the patient usually say, why me? Why me? Why I had this diabetes? There's so many person around me. They are fat, they're obese, they are not having any dietary compliance. Why I had this diabetes? Because first of all, you have to remove this you have to remove this his mental issue, or this his issue, psychological issue. Secondly, what we feel is that having the diabetes means that this is a totally the change in the lifestyle. Your life would be definitely changed, a 180-degree shift. So most of the patient, so they are reluctant to change their lifestyle, and they remain in the state of the denial after the diagnosis of the treatment, after the diagnosis of the diabetes. So definitely with the physician, they come across certain problems. To remaining sticking to my own presentation, can I have the next slide, please? So this is basically the tool which we usually use to screen the diabetes distress scale. It's quite comprehensive, but there are 17 areas which we usually address, and there are certain questions, and but I think as far as the Pakistani need is concerned, that we can translate it into Urdu in a very simple language, so the patient is able to answer these questions very easily, and he can seek the help of his attendant as well. Because, but when you see the scale, you can see that the question 1 is the feeling that all my doctor doesn't know enough about the diabetes and diabetes care. So this is very common, that the patient has a kind of a mistrust on the doctor, that the doctor has nothing to do with the diabetes management. He has little knowledge about the diabetes management. Probably he needs some specialized kind of care. And in front of this every question, you can see there are 6 areas. They are scored number 1, 2, 3, and 4, 5, 6. So this ranges from 1 to 6. The 6 is the maximum and very serious problem, and not a problem is a score 1. So there are if you go through the different question, the second question is the feeling that diabetes is taking up too much of my mental and physical energy every day. So probably they think that it's a 24/7 kind of thing which they have to manage on daily basis. Obviously, you have to manage on daily basis. It's a basically the change in the lifestyle and change in the behavior. and not feeling confident in my day-to-day ability to manage the diabetes, because they have you are confident when you have knowledge about the disease. If you know the right thing, and your physician or your healthcare provider, if that person guides you properly, so then you are able to manage your diabetes with confidence. And the fourth is the feeling angry and scared and depressed when I think about the living with the diabetes, because when the person sees so many people around and they are having so many problems and the complication with the diabetes, so they're a bit scary about it. But I think, and most of our physician, I think that this is my concern. Some of my physician fellows, they motivate the patient in a negative manner. So if they ask the person, if you don't take care of yourself and you are not taking care of your diabetes, you will have insulin, you will have your foot cut, you will have this problem. So this is the negative motivation. But I think the patient need a positive motivation. Obviously at times you can tell the person that you can land to the complication in a way that you are not taking care of yourself. But I think the positive motivation is more important. The fifth is the feeling that my doctor doesn't give me the enough time directions on how to manage my diabetes. But this is a very general problem on the part of the patient, that people are not spending much time with the diabetic patient. At least we should be able to diagnose it very briefly with a certain few questions, that this person is suffering from diabetes distress, and we can guide him properly according to that. If the person needs referral, we can send the person to the concerned person. And six, the feeling that I'm not testing my blood sugar level frequently enough. And what we see, because at times definitely you ask a person to buy the glucometer, and the patient is having the perception that probably he is going to check the blood sugar level every 4, 5, 6, 7 times a day. So obviously this is not even recommended. If you have stable diabetes, obviously you have less you have to check the blood sugar level less frequently. And if the patient is affording, definitely they can go for particularly the type 1 diabetic, they can go for the continuous glucose monitoring. But even what I have done to my patient, that I have given the sheet that you have to check the blood sugar level once a day. And you just keep on changing the timing. First of all, the day one, you check the fastings, the day second at the lunchtime and post lunchtime, and the day three you for the dinner. So if you have any abnormal feeling of the low blood sugar level, you can check at the same time. And during illness, you have the more frequent checking. But because the devices and the gadgets are such that they are more or less, they are painless kind of things. So you can remove the fear of the person regarding the frequency of the blood sugar monitoring. Feeling I will end up with the serious long-term complication no matter what I do. So this is a very, very negative point, because the person feel that whatever he does, for example, if he takes care of himself, he maintains the A1C below 7% or whatever the doctor has suggested, and whatever he does, taking insulin, taking the tablets or medicine regularly, even in spite of all this, he definitely is going to land into the complications. So you have to remove this myth and fear of this patient. Feeling that I'm often failing with my diabetes routine, because at times, because of their time constraints and the other they are not able to follow the routine of the, because
we can't hear you properly.
Can you hear me now? Can you hear?
Yes, Dr. Imtiaz, this is the problem with the mic.
Yeah, can you hear me now?
Keep the mic closer to your mouth.
Now, can you hear me?
Yes, please. Please go ahead.
So
very good.
So this is the very big issue, that the patient is feeling guilty about it, that whatever he does, that he's not going to manage his diabetes. Even if the better management, he can have the complication. So this is again a myth, and one that is the duty of the healthcare provider or the psychologist, that he should remove the myth and the misconception of the patient. The ninth is the feeling that the friends and family are not supportive enough to self-care efforts, because this is a very common complaint we come across in our daily practice, that family members, they act like the police. They have a very close watch and eyes on the patient, and they act like the James Bond. If the patient, so they report like this, that the patient gets up in the early hours in the morning and go to the fridge and take the piece of the cake with that. So you should not act like the policeman. So you just tell the person, if you don't take care of yourself, how to take care of yourself, how to overcome this problem of this craving for the sweet. So I think this is again that so in a this secondly, you might have come across the people during the summer. They are enjoying plenty of mangoes around, and the food which is and particularly in the marriages and the parties and the function, the people are enjoying the sweets and everything. So it's a kind of temptation for the patient. So I think that you should not put the patient into the trouble, and you should not give the temptation to the patient. So this is basically, it's a very difficult for the person, particularly when you are in the family, feeling that the diabetes controls my life. So the patient is not controlling his life. It is a diabetes, because it's the other way around. So this is again a myth, and it is the duty of a healthcare professional that the myth should be removed. Feeling that my doctor doesn't take my concern seriously enough, again the time constraint, and again the part of the problem on the part of the doctor, that they are not have enough time and they're not addressing their problems seriously. Feeling that I'm not sticking closely enough to a good meal plan, because at times the meal, what we have, the tailor-made or the tailor-made kind of the diet chart we usually give to our patient, they are not helpful. Absolutely, what I say in my clinical practice, it should be the customized. So you must seek the help of the nutritionist or the dietitian for in this regard. And feeling that friends and family don't appreciate how difficult living with diabetes can be. तो आपको क्या पता कि ये शुगर के होना कितना मुश्किल है, के साथ जीना कितना मुश्किल है. This is again the myth. You have to remove the myth, because it is I think when we talk about the type 1 diabetes, it is not the single person. Type 1 is a child or a young chap who is having type 1. It is the caregiver, parents, mother and father, and there are 3 patients. So they're all suffering from the same kind of problems. So obviously, it's like a teamwork, and you must seek the help of the family members. So it is, if the psychologist is arranging a session for the patient, it is not the sole session. It may be the sole session with the patient, but solo session, but it should be with the family as well. So family counseling is also very important. And feeling overwhelmed by the demands of living with diabetes, because every time the treatment plans are becoming more complicated and the dietary patterns are becoming more complicated. And obviously, so you have to overcome this issue as well. Feeling that I don't have a doctor which I can see regularly enough about my diabetes, because again, and this is on the part of the healthcare provider, they are not available. But even what I do in my set, that I try instruct to my patient that they can take the help of the WhatsApp, and they can send their voice message or whatever the note they want to send, and whatever the investigation or the tests, or they can share their reports with me. So I can answer their queries and the questions in the later hours. So 16th, not feeling motivated to keep up my diabetes self-management. So at times the patient in the very low mood, because the problem is overwhelmed, and he has to walk, he has to take care of his dietary plan, he has to take care of his medications, he has to inject insulin 3 or 4 times a day if it's type 1. So obviously the patient has loss of motivation. So if you lose hope, if you lose motivation, definitely it affects your diabetes management skill. So we should ask this question as well. So there are 17 questions. I just discuss very briefly, and the factor 5, and whatever the score comes, you grade the distress accordingly. The interpersonal distress is again the 3 items. So you item number 9, 13, and 17, and you divide by the factor 3. So whatever the score comes, so it is you grade the distress accordingly. So this is this is my part that we have discussed what the most of the questions, what we are having, what the problems we are having. The 17 question, although they appears to be lengthy, but I think when you take or seek the help of the psychologist, or you can train your some colleague which is so you can help you out in screening out these your patients. Thank you very much for your kind attention.
Thank you, Dr. Imtiaz, for such a wonderful talk on screening of diabetes distress. I once again, I request all of you, all of the participants, to provide us session feedback in order to claim CME. The participants submitting feedback within 12 hours would only be obliged for CME. Now it's the time to start question and answer session. We can take your question if it is there. We're having with us both of our speakers, Dr. Tahir and Dr. Imtiaz. You can ask question if it is there. After question and answer session, we will take comments from our panelists, but it's a time for question and answer session. Anyone from the participants? Okay, we can take your questions after opinion from our comments from our panelists. Now I will request our first panelist, Dr. Zaman Sheikh, to please comment on this on these two sessions.
Assalamu alaikum. Can you hear me?
Yes, Dr. Zaman, we can hear.
Okay, thank you very much, Dr. Mohammad Usman Musharraf, for your kind introduction. I'm happy to see Professor Javed Akram here and two great speakers, Professor Muhammad Tahir Khalili and Dr. Imtiaz Hassan, my old friend, Dr. Osama Ishtiaq. And I'm grateful to Ferguson's Mr. Basit Hamid and the team for organizing this wonderful academic session. Now, I've got few comments. Number one, we have got two challenges. Number one, to screen and then diagnosis the diabetes distress. And this should be differentiated from diabetes depression, which is a different entity. Actually, there is some gray area, overlap area, as Dr. Imtiaz said very nicely. So depression is something else, and the questionnaire for depression is PHQ type, say different questions. So of course there is a gray area. So number one challenge is to screen and diagnose these patients, and then of course how we manage them, treat them. Now how we screen, we see that many diabetic patients come to us, and along with other symptoms and signs we see. They mention, or their attendant mention, that he has got or she has got mood changes. This is commonly stated by either patient or their attendant. Now, when they say mood changes, this should make alarm in our ears that there is something wrong. And when you see HbA1c is not controlled, home blood glucose monitoring is either not available most of the time, they don't do. They don't do blood sugar. If they do, they don't write. If they write, they don't give bring them to doctor. So when you see this, when you see patient is not taking medication, cost there, but even if he can afford the medicine, and even then he's not taking medicine, this should point out this problem. And he's not bothered about exercise, about diet. He goes on eating, because these patients, they are most of the time depressed to some extent, and eating is a pleasure. So they feel pleasure in eating. Overeating, they become more obese, more worsening of type 2 diabetes. So if you find these things, mood changes, and compliance is not there, then you should think that he might have diabetes in distress. And number two, it is tricky to ask questions directly. Are you depressed? Have you got distress? It is like asking some people, do you drink alcohol? Obviously, he will say no. So there should be some indirect questions, like while asking alcohol, भाई कोई शुगर वगैरह तो नहीं करते हो आप, या कुछ पीते पिलाते इस तरह का कर जिस तरह कहते हैं प्याज से शुरू करो तो सारी बातें खुलती जाती हैं. So there shouldn't be direct questions कि आपको डिप्रेशन तो नहीं, आपको परेशानी तो नहीं है, इस तरह. तो indirect ये कि भाई we see many patients, they don't they cannot cope diabetes easily. So do you feel this? Yeah, do you feel difficulty in your controlling diabetes? Then he will say, yes, I feel difficulty, and then he made the. And Dr. Tahir Khalili mentioned about the diabetic burnout. Now, this is very serious condition. Patient knows that he is facing he has to face complication. He knows the complication, but even then he is not bothered to do these tests, to take medication. This is known as burnout cases. Now, these are advanced cases. It is like initially one has got hypothyroidism. If you don't hypothyroidism in time, it will lead to mixed edema. The classical pictures we see in textbook, they are of mixed edema, not of simple hyperthyroidism. And if you don't treat mixed edema in time, patient will go into mixed edema crisis and mixed edema coma. So these are the stages. So to prevent burnout, which is a very serious condition, patient knows that he is facing complication in near future. Even then, he is not bothered. Why he is not bothered? Because of stress. Because of seeing that same medication, one day it is working, second day it is not working. So what is the use of taking medication? Obviously, there are so many factors: stress, exercise, planned, unplanned, and dieting. So many factors affecting the blood sugar. It is not easy to control blood sugar in 24 hours. It is not. So my paid question is, sometime this sugar will be high. Sometime this should be low. So don't worry. But it should be occasional, not daily affair. If daily affair, then we have to change medication or see some other factors like compliance and other things. So to prevent burnout, we have to diagnose diabetes in distress, to treat it timely. And number one, sometimes it is iatrogenic. We give stress to the patient. Bhai, 7 dafa sugar check karo. Who will check 7 times a day? Even we cannot, doctors, if we are diabetic, we cannot change. Either if a patient is affording, he should buy this Libretype and then check anytime 200 times a day, then it's possible. The problem is it's very expensive. So to stress the patient that you should bring chart with 7 days daily, this will put stress. And number two, sometimes we are strict in dieting, in exercise. Exercise. Who will do 1 hour exercise? It is practically very difficult. Chawal bilkul nahi khao, roti bilkul nahi khao. These mangoes, rice, they are not poisons. If they are taking 1 slice of mango, blood sugar is controlled, or even borderline high, there is no harm. He should enjoy the life. And it's not cruel disease. कि भाई आप सारी चीज बंद करो, सिर्फ आप दाल खाओ और वेजिटेबल खाओ, रूखी सूखी, इस तरह नहीं है. Patient can take everything. So you should not stress the patient yourself. You should try to lessen the stress which is already there. So these are my few points, and thank you very much once again.
Thank you, Dr. Zaman, for your valuable comments on diabetes and depression. Diabetes distress. Our second panelist is Dr. Usama Ishtiaq. Dr. Usama Ishtiaq, I will request Dr. Usama Ishtiaq, please share your comments on diabetes and depression and diabetes distress. Dr. Usama. Yes, we can hear.
Okay. And thank you for inviting me. And although this topic is least discussed, but it's an important topic. You all know, and already has been discussed already, good presentations by the speakers, especially Dr. Zaman Sheikh has pointed out very, very important aspects. I'll just focus on basically one aspect, how you measure basically diabetes distress. It's not that much uncommon. It's very common in our most of the patients, especially in type 1 diabetics and type 2 diabetics who are having a long duration of diabetes, who have developed, especially the complications. And especially also in those patients who have a brittle diabetes, no matter whether they are type 1 or type 2 diabetics. And coping diabetes, controlling diabetes for 365 days a year, even 24/7 job, it's not an easy task, you all know. So I would just focus on how do you measure this basically. Diabetes distress scale has also been discussed, but another one is the PAID basically. Problem areas in diabetes questionnaire basically. It's a 20-item questionnaire. And all these questionnaires that have been designed to measure this diabetes distress should be smaller questionnaire, chote hone chahiye. Why? Because of the fact it's not easy to take history in detail of each and every patient that visits you actually. So unfortunately, DSS basically that has 17 items, while the PAID questionnaire has 20 items. There's the Urdu version of this PAID questionnaire. I've heard that it is there, but I don't have at the moment. But some clinics in worldwide, what they do actually, they before seeing the patient, they ask the nurse to give the questionnaire to the patient and fill the questionnaire before visiting the doctor. So when the patient comes to the doctor and then doctor reads that questionnaire and then assess accordingly, basically, have scored more than 40 indicates severe distress basically. Because the total score of 100 out of 140 score in a PAID questionnaire is suggestive of impaired problems. So a doctor can ask, but how you feel when you answer these questions. That's a very important aspect, because patient should be on board while you ask these questions. And then you can ask the patient, what do you think, what's wrong with your diabetes and how you are different from other patients. So when doctor should be empathetic, should clearly listen to the patient. All that depends how much time you give to the patient. Busy doctors who have to see many patients in a short period of time find very hard to discuss these things with the patients. So my suggestion, my advice to all the listeners is that give some time to the patient, listen the queries and the concerns of the patient, and how to cope their distress, how to manage distress. I've seen a lot of patients who Okay, thank you. So if you think the patient has developed depression or a burnout, it's better to send the patient to a psychiatrist or psychologist, because they are more expert in dealing these conditions. And I've seen personally that patient who has a good mood, whose depression is cured, who's settled, they tend to improve their glycemic control, they monitor their blood sugar, they improve the diet control, compared to those patients who are in depression, who are in burnout state, who are in distress, tend to lose their diabetes control. So you should not see the numbers, you should not adjust the medication, you also should address their mental concerns, their distress concerns. And believe me, if you improve their depression, if you improve their distress, their diabetes control definitely improves. Thank you so much.
Thank you, Dr. Osama, for your valuable comments. Now there is an announcement that Professor Dr. Javed Akram won't be able to join us because of some emergency. So now we have we will start question and answer session. You can ask any question. You can post your question in chat box, or you can directly ask any question from our speakers. So my first question is from Dr. Imtiaz, for Dr. Imtiaz, that which antidepressant is safe for people with diabetes and depression? Which antidepressant is safe? Dr. Imtiaz. Dr. Imtiaz, can you hear me?
Dr. Usman, I think Dr. Imtiaz logged off. You can ask this question to Dr. Zaman Sheikh or Dr. Sama.
Okay, Dr. Usama or Dr. Zaman Sheikh. Okay, from Dr. Zaman Sheikh. Dr. Zaman sir, which antidepressant is safe for people with diabetes and depression?
Okay.
What is
Thank
your
you very
opinion?
much.
What is?
Thank you very much. Actually, we cannot say that this one is the best. All other are rubbish. We cannot say this because some antidepressants they suit some persons. But we have to see some scientific evidence. Now, when we were young doctors, we used to treat with tricyclic antidepressants, very potent, very good, analgesic quality as well, but so many side effects, so they are almost gone. Then many antidepressant SSRI, NRI type they came. But latest modality is latest version is multimodal, which affect on many receptor, many neurotransmitter at a time. So these are new things. So we try to use these type of which are safer, which don't have interaction with other drugs, which we use for hypertension and diabetes, and they are comparatively safer. They don't have irritation type of side effects. They don't increase the body weight. So these are comparatively safer, multimodal. So we try to give nowadays these type of antidepressants.
Okay, thank you, Dr. Zaman.
What you sent in is one of them.
Okay, Dr. Zaman, thank you. So second question is for Dr. Tahir. Sometimes we feel very difficult to convince patients with diabetes to visit any psychiatrist or psychologist. How we can tackle this situation? Sometimes people with diabetes and patients with diabetes, they are reluctant to visit any psychiatrist or psychologist.
I think it's a reality, and it's very hard to convince the individual who is suffering from diabetes. And at the same time, if you ask him or her to go to consult psychologists or psychiatrists, because social stigma is very much attached to mental illness. And if you say something to an individual that you are suffering from mental health problem, I think I will take Dr. Zaman point that we need to, in a subtle way, we shouldn't give them a label suddenly or quickly, but we need to discuss with them that because you have a lack of sleep and bad mood most of the time, and you cannot concentrate, and you have you forget important things, and you can't make decision, then these things are related to stress. And there are certain medicine which are available to manage the stress level or to manage your mood problem. You won't say that you are suffering from depression also, but you can say that you have these mood variations. Like Dr. Zaman said that we shouldn't go for labeling. Then I think if you, in a subtle way, analogy, the diabetes, when they tell the patient, then the patient can understand. I still remember one of the patient, the endocrinologist tell him you can't use insulin, and if you can't properly, you can't manage your glucose level. It can affect your brain, and that can affect your cognitive function. and even that can cause cognitive impairment. Then the person in question was ready to get insulin and to take insulin, and then he was convinced. I think there are ways and means, and like Dr. Usama said, empathetic. If when you show empathy, when you show your understanding, when you are sincere with your counseling and you are convincing, I think it's the best strategy. Then you can motivate the client, and then you can ask. But anyhow, if there are certain, as I said, that there is one common thing in our culture that which we call optimism biasness. We have this optimism that no, I'm okay, the other person has a problem. And this is a big issue in our country. But anyhow, we have to work with this. This is a challenging task. There are rigidity, there are inflexibility, but we have to work like the physician. Physician has very good tolerance. He's not like the surgeon just to cut the things and remove. Physician is waiting. He is waiting to get the results with the passage of time. Then I think we have to persuade and we have to motivate, use different techniques. Sometimes you use that you can develop some fear, and the person will get motivation. Sometimes you will give him hope that that will improve your quality of life, your relationship with your wife, or any other thing you need that can reinforce the behavior which you would like to the person adopt. Then I think that is essential. Thank you very much.
Okay, thank you, Dr. Tahir. We have another question for Dr. Tahir, that we see so many patients with depression and diabetes in our clinical practice. Should we refer that patient with depression to psychologist or psychiatrist? Question number one. And second question is, so many medicine and people usually come back to endocrinologist or diabetologist or physicians complaining of that they sleep all the time with so many medicine, so many antidepressants. How we are going to deal with this situation? First question was, should we refer him to psychologist or psychiatrist? And second, the polypharmacy, the so many medicines used by psychiatrists is sometimes patient, they become non-compliant to even antidiabetic drugs. How we are going to tackle
I
this
think
situation?
this is a $1 million question to answer, and it's a very important question the person asked. The first one is like, look at the level of severity of the depression. As I said, like we are using these scale, diabetic distress scale and other Dr. Usama mentioned. But at the same time, I mentioned that DAS. DAS is depression, anxiety, stress scale is available in Urdu. And they can tell you about the level of depression, anxiety, or stress. Then if the depression is very high and the person won't comply to the talk therapy because of the education, lack of education and lack of awareness, some people, they are not ready to come to the psychologist, and they think that they will be treated with the medicine or some procedural treatment will be very effective, like we are using now neurofeedback therapy. Then they will be effectively treated. Then just consult with the client, and if you look at that he's agree, then he should be or she should be referred to psychiatrist. Or if he's educated, he's aware of the importance of talk therapy, psychotherapy, counseling, then you can refer him or her to psychologist. But there, you mentioned a very important point, and maybe the physician, they are here, very well-known physician, the irrational use of psychotropic drugs. I think this should be rationalized. This is in every prescription, even in the GP prescription, you will find 2-3 psychiatric drugs, anxiolytic and sleeping tranquilizer. They are just writing. You know, I think it's not helpful. Whenever you need, you can write. If you don't need, like suppose someone has failed his exam, then this is a natural reaction and he will be depressed or she will be depressed. and this is a reactive depression. They need some time, they need some discussion, they need some skill to develop. And once they develop the skill, then they can improve, and then they can pass their exam, or they can pass their interview, or they can pass their viva. This is just a simple thing. That's why I mentioned that at the primary care level, our diabetologists and psychologists, they need to extend these services through the counseling at the primary level, that the doctor or paramedics or any other one who is a person who is dealing with these clients at least could talk for 10-15 minutes and could counsel them, could talk them, even if you, and even they will not get a bad advice. Sometimes when they go to the quick, then they get a very bad advice from there, and then that is counterproductive. Then I think I will again request the Association of Endocrinologists, Diabetologists, that they should organize intensive courses, short courses for the general practitioner, healthcare professional to have this knowledge of counseling and diabetes, then they can provide. I think this will minimize the burden on the health services as well.
Thank you, Dr. Tahir, for wonderfully explained question. Okay, my next question is for Dr. Usama. Dr. Usama, being an endocrinologist and diabetologist, you see so many patients in your clinical, in your practical life with depression and diabetes. And how you refer these patients to psychiatrists or psychologists, how you convince these patients to go to psychiatrists or psychologists, because in your clinical life, in our clinical practice, people usually they are not convinced to visit any psychiatrist or psychologist. Can you please share your practical experience with us?
I think Dr. Usama just logged off. Dr. Samanche is requested to answer this question, please.
We cannot hear Dr. Zaman. Dr. Zaman, we can't hear you.
Now, can you hear?
Yes, we can.
Okay. Now, this is very important question. Many patients, there is a stigma. If we refer direct to a psychiatrist, they feel that they are a psychiatric patient. So they say, sir, we are not a psychiatric patient. हम पागल तो नहीं है. हम psychiatrist के पास क्यों? Still, there is impression that only पागल people go to psychiatrists, which is quite wrong. So they resist actually, and there is no need actually for initially sending these patients to psychiatrists. When either the patient says, sir, I need help, patient is willing, then. Number two, if endocrinologist feel that now he cannot deal with this degree of distress or depression, whatever it is, when patient feels, when doctor feels. And number three, when disease is severe, both say no, but disease is very severe. This is third option. Fourth option, when patient is very much stressed, or there are some comorbidities, then it is better to refer to proper place. Initially, we can try ourselves, and majority of patients we see in routine clinical practice, they are benefited by endocrinologist. But when you feel that we cannot deal ourselves, endocrinologist, disease is severe, and especially patient is willing, after counseling, of course, or without counseling, then we should refer. And if disease is severe, degree of severity is more, then we should refer these patients to psychiatrists with a note explaining all the things. Thank you.
Thank you, Dr. Zaman. So I will again request our participants to ask any question if it is there. Any question from our participants? So I think we don't have any further question. At the end, I would like to thank both the speakers, our both panelists, and all the participants are joining this wonderful session that was organized by Ferosan Pharma on very important and common complaint of patients with diabetes and very neglected complaint. So thank you everyone for your active participation. Allah Hafiz.
Thank you. Thank you very much.
Allah Hafiz.
Allah Hafiz.
Sir, thank you very much for the nice